All right, good morning, everybody. Welcome to Pediatric Grand Rounds. My name is Mary Leonard, and it's my pleasure to welcome you. So first, we'll take care of a few housekeeping matters. On the left here, just make sure you have the information you need for CME and MOC credit. And then very proud, as always, to show you the speakers we have in the next couple of weeks. There's always an incredible lineup. Next week is a very special event. The Harvey Cohen Endowed Lectureship in Pediatrics honors our rising star physician scientists every year. And we're so pleased that this year Sushma Reddy from cardiology will be giving the Harvey J. Cohen Endowed Lectureship. And then the following week is another very important endowed lectureship, the Redeem Marie DiCarlo Lectureship Series. And we have the great pleasure of hosting a former state senator, Richard Pan, pediatrician, who's been an extraordinary partner for all of us thinking about childhood advocacy. I want to, as always, do our university land acknowledgement that Stanford sits on the ancestral land of the Muwekma tribe. And a couple really important announcements. It's that time of year. Want to make sure everybody's getting excited about the Pediatrics Research Retreat on Thursday, April 25th. This is really a wonderful opportunity to meet some of our new faculty, to hear from our extraordinary trainees and some of our very distinguished scientists. And our keynote lecturer will be Michelle Monge, who's doing such incredibly exciting work in partnership with Crystal Makel and others in their work in pediatric brain cancer. She's a very, very preeminent neurobiologist. And so it's a really fun, interactive day with a lot of great energy for the whole day. So please join us in person. And then this is a new event that we're doing. The Maternal and Child Health Research Institute Clinical Research Support Office is an extraordinary resource if you're doing any research that touches patients, whether it's in the hospital and you need custom EPIC order sets or a portal to get pathology specimens, or you need the investigational drug pharmacy, or outside the walls of the hospital and in communities of people who are not our patients through the school systems, and where you need there's a Office of Community Engaged Research. And we really wanted a chance to bring our whole community together so everybody could see the depth and the breadth of these incredible resources, and an opportunity to just community building in our research community. So this is an MCHRI event, and really encourage everyone to join us. Faculty, staff, your research coordinators, everyone really should come and learn from each other and learn more about the resources that are available through MCHRI. And with that, it's my great pleasure to introduce Alyssa Burgart. Alyssa is well known to many of us. She's been such an incredibly sage source of wisdom for me in many different ways. She's an clinical associate professor in anesthesia with a courtesy appointment in pediatrics. She specializes in pediatric abdominal transplant anesthesia. So most of my interactions with Alyssa have been at 2 a.m. in the PICU. When the kidney transplant patients come out, we get a lot of work done at 2 a.m. She is the Associate Director for Pediatrics at the Stanford Center for Biomedical Ethics, a new role. We're very pleased she's in that role. She is co-chair of our Ethics Committee and a member of the SHC Ethics Committee, provides ethic consultation services for people of all ages. Her ethics interests include pediatric ethics, organ transplantation, community skills, disability rights, women's healthcare access, adolescent decision-making, ethics education, and excellence in ethics consultation. It's quite extraordinary, Alyssa, to look at your publications, everything from chemical restraints for obstetric violence to the opioid crisis. It's really a very impressive body of work. The reason Alyssa's here today is because she recently authored a really important paper around algorithm bias in AI. And when I read it, I realized what an incredible sort of gap this is in what's happening with AI. So the Maternal and Child Health Research Institute is going to be working with Alyssa and others on this campus to put together some sort of an RFA to create some seed grants to support this kind of work, because as everything is happening in AI, the whole paucity of pediatric data and the really important implications, ethical and otherwise, is quite urgent. So with that, Alyssa, thank you for joining us for Grand Rounds.
Making sure the microphone works. And is this off? Okay, thank you. Thank you so much for having me and for that lovely introduction. I often joke that being an ethicist at a hospital means you kind of have to be the general pediatrician or the family medicine doctor of ethics, because you have to kind of know a little bit about a lot of things. And so it is a little odd. I don't consider myself an expert in AI. I'm not a programmer. I used to be able to program HTML, like make some cute websites, and you know, web development has advanced far beyond my capabilities. But I don't think it's possible to do ethics right now without thinking about and understanding the implications of artificial intelligence and machine learning. And so oftentimes I think about the 2-year test, like what have I learned in the last 2 years that has become integral to my knowledge, but that maybe you don't know that much about yet. Some of you may know more about this topic than I do, and I look forward to continuing to learn. And I'm hoping that I help many of you understand a few extra things about AI that can help you to think about these issues as you move forward in your practice. I have no financial disclosures. My disclosure is that I am not a tech person. All of the images that are in here, if they're not from a news source or from like a screenshot from a journal, they were all generated by DALL-E, which is one of the image generating softwares that's pretty widely available. I always think it's really funny because you can tell it exactly what to say and it will absolutely spell it wrong, no matter what. I have yet to create an image in which I gave it the text and it spelled it correctly. So it's just kind of funny when you start to notice some of the things that it does a great job on and some of the things that this technology will still struggle with. I do want to have a content or an activation warning. I'm going to discuss some serious issues that have to do with harms to children, and that's going to include sexual abuse of children. And if that's something where you cannot be here for that, you can go. You don't have to explain yourself to anybody. But as pediatric providers, it's something I think it's really important that we discuss. So today, the things that I'm going to talk about, we're going to talk about recognizing pediatric algorithmic bias and the unique risks that this poses to children. I want you to understand sort of the generational implications this may have in terms of using pediatric data, and whether it's including or excluding pediatric data, and identifying how that data being used in training models and algorithms can meaningfully impact end users. So when we think about the myriad of issues that impact children, AI is going to be something that we have to think about, because we have to think about not only what is the data that's going into those training models, but what are the outputs that are coming out, and how is it that will impact children. Moral outsourcing is a term that was coined by Dr. Ruman Chowdhury, it was previously the head of ethics at a number of tech companies, no longer there. So moral outsourcing is the anthropomorphizing of AI to shift the blame of negative consequences from human beings who are making, generating, and creating these algorithms, anthropomorphizing the actual tech. You know, no one says, like, I have never looked at my toaster and said, my toaster is racist. I have not. I have never done that, because it is absurd, the idea that my toaster is the source of racism or the source of sexism. And so moral outsourcing is this idea that we're taking choices that human beings are making, and we are putting those on something that is technology that is actually created by humans. And this is a quote from German philosopher Hannah Arendt, who studied the aftermath of Nazi Germany. You know, how was it that ordinary people became part of such a terrible systemic injustice? And one of the quotes from one of her books, the sad truth is that most evil is done by people who never make up their minds to be good or evil. And so some of the sources that she would talk about is like, I was just a truck driver driving human beings to be murdered, but I was just a truck driver. I was just doing my job. And so thinking about what is the operationalization and the impacts of the roles that we play. Another idea I wanted to introduce is this idea of the coded gaze. So the embedded views that are propagated by those who have the power to code systems. And Joy Buolamwini has written really extensively about this as a data scientist and as an artist. She is often referred to as the poet of code. And so thinking about what kind of gaze are we creating when we create algorithmic systems? These are learning systems. So if you think about machine learning, the point is that you're able to provide a lot of data. You're able to code it to think about that data or to utilize that data in certain ways. It's going to amplify the benefits and burdens of that information. So whether your data is accurate, whether it has integrity, How does it apply to a population? So if you're only including certain population data, who is being excluded or included in that data set? And how is it that we may either amplify or diminish that information? And how is it that we might utilize tools like unlearning for information that we do not believe needs to be or should not be in that data? When you read about AI and ML in the popular press, you'll hear a lot about like, oh, the data set, and oh, this data set or that data set. And it can be like, what the heck are they talking about? And so there are lots and lots of different kinds of data sets. Some of those data sets are generated by hand by human beings. Those are things where maybe they source a bunch of data, but the data is specifically analyzed by a person to decide what does this data tell us? How should it be coded? How should we think about this piece of information, whether that's an image or a document or something else? Some of these are custom machine generated. So you dump a bunch of information in and you say, oh, look for patterns, code these things in some sort of a pattern. There are things related to natural language processing. There are open data sets, which are things that are they're publicly available. They can, they're trolling all sorts of data from the internet. Anything that's publicly available can be included there. There are government data sets that are public. There are audio data sets. So, if you hear about somebody who's doing research on like bird calls, they can take, millions and millions of audio files of bird calls and try to figure out what kind of bird is singing in some very particular place. There's custom image data sets, and then there's things like healthcare data sets. So I think it's important when we think about the implications for children, it's, I think, critical that we don't forget that not all the data sets are health data sets, and that there are non-health data sets that can have very important health implications for our patients that we care about. Some of these are paid, some of these are free, some of these are easy to get, some of these are hard to get. You can buy them from Microsoft, you can buy them from Twitter. There's all sorts of things that you can buy. X, we're not calling it Twitter anymore, I guess. So pediatric algorithmic bias is something that my colleagues and I, and I'll talk about our work, we just realized we didn't see anybody talking about it. And we thought, gosh, there's a lot of different vulnerable populations, and we know that children are one of those populations. We're hearing a lot about racial bias, which is incredibly important. And we know that those biases are also impacting children also in unique ways. And so algorithmic bias generally is the systemic and repeatable errors in a computer system that create unfair outcomes, such as privileging one arbitrary group of users over another arbitrary group. So for example, when we think about children, we might think about prioritizing data that only comes from adults over data that comes from children, or ignoring the existence of children altogether in a data set, and then perhaps applying that data set to children and assuming that it will perform as efficiently as the same data set may apply in adults. And you can certainly get much, much more granular into this. So, if you have a cardiology data set of like echoes, if it includes all comers, it's going to perform differently than if you say, well, we're not going to include, for example, children with very specific types of cardiac conditions. How is that data set going to perform depending on what data you've included and who are you attempting to apply that data on? And so there are many different aspects that can contribute to pediatric algorithmic bias. And certainly this is not an exhaustive list, but I just want to give you sort of an idea. You can have data sets that are simply incomplete. They don't include the kinds of participants that you want to be able to examine. If you make a data set, like if we go back to that cardiology example, if you don't include any kids with single ventricle heart disease, but you try to apply that algorithm to children with single ventricle heart disease, like you shouldn't trust the outcome. It kind of doesn't make sense. You have data that's completely unlabeled. You have no age-related data at all on some of this. And so I don't know if I'm looking at data from an adult or I'm looking at data from a child. How is the algorithm going to determine what to utilize that data for if we have not told it what the data is? You have indiscriminate data. So again, data that's just been trolled from the internet is just dragging along, pulling up whatever it can find. And the machine itself is determining what it believes the data to be. and there may not be any checks and balances on that data. So you can have biased data sets, you can apply adult data sets to children, you can apply specific PEDS data too broadly. So if, let's say you only collected data on single ventricle hearts, but then you try to apply it to, you know, typical hearts, it's not going to make sense. So thinking through what are the different ways that the data that I collect and utilize may inadvertently disadvantage systematically the patients that I am attempting to make decisions for. So this age data really matters. And these are things that can actually be coded. But if you don't have data reporting of the age in your data sets, then you're not going to have any idea. If you don't have, just in general, there's a lack of representation of children in existing AI and ML data sets in research. So this means that they're not necessarily diverse and inclusive data sets. You may have inappropriate generalizations, not only from peds to adults, but also from adults to peds. So you wouldn't want to take a pediatric data set and try to utilize that to make broad assumptions about adults. So why does this matter to the children that we treat? So I want to go over just a handful, and there's a growing body of literature demonstrating why this kind of bias is really important. And so I wanted to bring your attention to a few things that I think are relevant. So this is a really interesting white paper on artificial intelligence in radiology, impact on pediatric patients from the ACR Pediatric AI Working Group. And so what this group looked at was, you know, in radiology, what does the pediatric data show us? What can we learn? What kinds of assumptions can we make? And where is it that we're perhaps in really dangerous territory? And so they found that of the over 200 AI softwares that were medically device cleared by the FDA, only 3% were specifically intended for pediatric use. And there was actually no computer-aided detection, computer-assisted triage and notification software, or computer-aided diagnosis radiology products that were specifically authorized for pediatric use. And so it's important to recognize that, especially in radiology, where obviously there's a lot of both interest and concern in the role of AI in the future of the specialty, realizing we have an entire population of patients that we care about, and there's almost nothing. There is almost nothing. And it's really important in groups like radiology, where we don't expose children to the same doses of radiation as we expose adults to, because children are not little adults. And I know as an audience of pediatricians, you all know that. But the folks who are developing these things for adults may not be aware of that. And folks who are engineers who are not pediatric specialists may not have any insight into the fact that these models are not necessarily just widely applicable across ages. Another piece, again, from echocardiography, because I think that's another interesting area to think about. This group did something really interesting where what they did is they took a bunch of, they ran a program across a big data set of echoes in adults. This is adult data set, and they wanted to see how it would perform on pediatric echocardiography. And it was really interesting because they had physicians and expert physicians analyze each of these scans, and then they had the AI model look at them. And they tried to look and see what was the agreement between the clinicians who had a lot of experience. And we know that there's wide variation across clinicians as well. So that's something that can be tough for us to sometimes accept as doctors, that we don't all necessarily come to the same conclusion either. But also, what was their agreement with the AI or opposed to the AI? And so the aortic annulus and the E-wave, the adult model performed very well across all ages. So those were two measures where that was an effective tool to utilize, even though it was developed for adults. Looking at the sinotubular junction and looking at EF really was only effective for patients over 9 years old. So as patients got bigger, as their hearts got bigger, as they got a little bit closer to being adult sized, those elements performed much better, and there was good concordance from clinicians and the measure. Now, for other measures, there either was good agreement amongst clinicians, but not with the AI, or there was just poor agreement all across. And so it's important to recognize that you can't just take an adult model and flop it onto a pediatric population and assume it will perform as well. And this is going to be really hard for us as clinicians, because there is a big push to try to really embed as many of these models into our work as possible, to try to make us as efficient as possible, try to get as much out of us as possible. And if we aren't even aware of where the data came from, of how the model was generated, we don't have any idea how that model was trained, it's hard for us to know, do I trust this output or don't I? And so we're going to need to be very skeptical as these models roll out, and being clear about what we can and cannot trust. Another really interesting example was this chatbot called Tessa. This was a mental health chatbot that was put out by Netta. And unfortunately, this model was supposed to only include certain types of advice for patients, for people who were utilizing it. Folks, it was a publicly available chatbot. And the makers of this model actually adjusted it so that the model could start making different recommendations than the things that Netta had specifically designed it for. And unfortunately, what happened is it ultimately had to be pulled down, because the model was starting to give some really dangerous advice to people on the internet who had no additional help or oversight. And so what this chatbot was doing, for example, was that for people who had who already had restrictive eating disorders, who already had other conditions that were potentially very dangerous, they were actually getting dieting advice. This model was telling them how they could cap the number of calories that they were eating, and it was actually promoting the sort of negative behavior that it was supposed to be helping to prevent. So rather than providing mental health support, it was actually exacerbating certain populations. So again, we can't just indiscriminately put out these things, especially because with the large language models, with natural language processing, you all have probably noticed, almost every website you go to, there's going to be that little button in the corner that's like, do you need help? Chat with an expert. And you're chatting with an AI, you're chatting with a chatbot. And until you get to the point where the chatbot doesn't know what to do, and then maybe it'll bump you to somebody who has a little more experience. And this is where I'm going to get into some of the issues of where this can get even more dangerous, especially when we think about data sets where we have no insight into what is in those data sets. And so child sexual abuse material is something that is a major, major, major problem on the internet. And this has been a problem since the existence of the internet. And AI is making it possible for this to get a lot worse, a lot faster. And so there's a really cool group at Stanford called the Stanford Internet Observatory. And they've been doing some really fascinating work analyzing these data sets and figuring out how is it that this information has gotten here, what can we do with it. So there was a Lion 5B2 is one publicly available data set. It actually had to be pulled down after this report came out because they found that there was so much child sexual abuse material that was in this data set. And so they found hundreds of known images of child sexual exploitation, and these were being utilized in popular AI to image generation software. So the kind of software that I use to generate these images, there are people who are highly motivated to utilize this information to make hyper-realistic images of children. And these are not only dangerous for, in general, we don't want this material to exist. They're also dangerous because these are images of children who have already been exploited, and then those images can actually be made into new images of different ways that they could be imagined to be exploited. So you can imagine how this is incredibly troubling for people who know that those images are out there. They're very difficult to remove from the internet. They're very difficult to escape from. And so, victims are having new images appear of them that never happened. It's like a really unique form of gaslighting to put victims through this again and again and again, potentially billions of times. And when you have publicly available data sets, it's very, very difficult to intervene on these. These are two documents, and I'll have links to everything for you in an easy to access thing at the end. I really recommend these two data sets. They do not include any child sexual abuse material. I want to be clear, there is nothing in these, there are no visuals in here that you need to be concerned about, but it does help you understand how it is that these data sets can be utilized in ways that are incredibly harmful to our patients. So one of the SIO reports really talked about how is it that we remove this terrible information from these data sets in order to prevent future harm. And these were listed in order of how difficult it is to remove it. So if you need to get data removed from the original source, that's the easiest thing that you can do. Trying to get it removed, the metadata entries, which is sort of the coding process that's available for each of these, that's the next hardest thing. Removing the actual images from the internal reference data sets gets a little bit harder. Removing those from any downloaded copies, that gets a lot harder. And then removing them from the models themselves. And this is one of the things when people talk about, oh, the black box of AI and ML, like what's in it? I don't know. And it's because we don't know. Because once that training data has been used and it's trained the algorithm to look for certain things, or to replicate certain things, it is a lot harder to backtrack that because these systems are changing over time. And so these are some of the images, the things we have to think about in terms of ethical AI and what does that even mean? And it's one thing for people like me who like love philosophy and sitting around and thinking about things, like that is a very different process than if you're an engineer and you're like, I want to build a system that does something awesome. And I think if it takes us back to that idea of Hannah Arendt's quote, you know, people just want to know how to do the right thing. So we have to ensure that we're helping people understand how to do the right thing and operationalizing what that means. This piece just came out, I want to say about a month ago, an overarching framework for ethics of artificial intelligence in pediatrics from some colleagues at Washington University. And they had some really nice philosophical questions, which was, is it true, is it good, and is it wise? And this was a framework that was utilized to think about research ethics in a different context. And so the first question they asked is it true? This question refers to whether the outputs of AI-based technology are trustworthy, which includes accuracy, reproducibility, and verifiability. So these are questions that we can ask as users. Is it good? This question refers to whether the AI-based technologies improve healthcare delivery and benefit patients, families, clinicians, and/or public health. Is it wise? How can we establish processes for wise decision-making? Because wisdom's kind of hard. It's hard to define that sometimes. And so I think these questions are really nice. I think they're lovely. I don't think that these questions actually help people who are building these models, who are training these models, and who are consuming these models. I don't know that these really help us operationalize how to provide safer care, how to ensure our patients have access to safety, joy, developing into the kinds of adults that they hope to develop into. So I really want us to think about how it is that we operationalize our ethical values. How is it that we take our values and we ensure that they are built into, from the ground up, accountable, equitable systems? And so my colleagues and I came up with this concept, Accept AI. And the way that we were thinking about this is these are some of the ethical frameworks that we think should be embedded in every program if you're going to accept it into use. So I won't say that it's wise, but I will say I think it's wiser than not thinking about these things. And I'll be honest with you, when Vijaytha Muralidharan first reached out to me, I was like, I don't care about AI. I don't want to think about that. Whatever. But she hooked me. And then I got to spend time with my colleague, Dr. Deshane, who does a bunch of research in AI bias in dermatology. And then I got to meet Sherry Rose. So it ended up being a really fun project to work on, to really think about what would it mean if we did operationalize these systems. And so when we thought about pediatric characteristics, we thought, okay, well, they're physiologically and anatomically different from adults, like we talked about earlier. We know there's heterogeneity even within a particular age, not only within developmental stages, but also just development in general. Not everyone's going to develop on the same trajectory. We know that children are supposed to be a protected research population, and we realized that folks that we'd talked to in industry didn't necessarily even know that. And that there's just unique ethical considerations. You know, it's a different conversation when you're talking about including somebody who's 4 years old versus somebody who's 14 years old. How are we utilizing agency? What does that look like when we're talking about methods, about training systems that are going to develop over time? And so the first part of Accept AI is age. So what is the patient's chronological age at the time of study enrollment? And we were thinking about, we thought that the people who would be most interested in this, honestly, were pediatric researchers. It turns out industry are the people who have reached out to us the most after we published this. And I'll talk to you a little bit more about our next steps. But like, what is the patient's chronological age? Are we keeping track of that in association with the data that we're collecting? When it's applicable and available, what's their developmental stage? What was their level of participation? How can we include relevant milestones? You know, if you're collecting data where that is going to be relevant, how can you collect that in a way that is accurate and sustainable? If you don't have access to some of this information, label it as not having access, as opposed to just leaving it completely unlabeled and you won't necessarily even know. And how is it that we can make sure that you're clear when you're developing an algorithm, who is it for and who is it not for? Who is included, who is not included? And age is one thing that you can utilize that's a very important piece of data, so that at least you would understand that you're looking at data from people who are, you know, neonates to 1-year-olds versus 14 to 16-year-olds. Communication. How is it that you're actually going to communicate AI and ML studies to people who are actually most impacted by it, which are children and young people? So how are we ensuring that we're engaging key stakeholders in developmentally appropriate ways? How do we make sure that we're helping people understand what inclusion or exclusion might mean for them, as opposed to what it might mean for somebody else who has some other reason to want this information? How are we communicating with parents or legal guardians? How are we ensuring that patients who are in, you know, less typical family structures, how are we ensuring that the communication that's happening with those families makes sense? Are we providing information in a way that families can understand? I think this is really complicated. I think this is complicated for people who have, you know, medical degrees and PhDs and all this sort of stuff. So how is it that we're defining explainability, and how are we ensuring that the populations we're working with are actually able to get the information they need in order to make decisions? Consent and assent, the gift that keeps giving as an ethicist. There was a time in my life when I was like, consent, nailed it. And yeah, no, that's not true. We are still every day learning about how to utilize consent and assent. And it's not just clinical, right? Like things like this, how do you decide whether you're going to be included or not? Are children who are included by their parents going to somehow be able to get out? Is there a mechanism for that? If there isn't a mechanism for that, are we being honest with people about that when they are included? Are we being clear? And I think a lot of times we see this in research as well, where people are like, well, I don't want to ask people because what if they say no? Yeah, what if people say no? What if we listen to them? What if we took that seriously? What if we actually asked and we respected the answer? What a concept. And I think that these are things that we can operationalize. When you have kids who are getting older, like, I don't think that we should make major decisions about 12-year-olds without including them. That seems to me like an easy standard that we should be able to utilize. Now, again, when we think about these open data sets, they're just trolling information from the internet, you get nothing. Because many of us have sacrificed privacy for convenience over the last, 20 years, really, with the development of the internet. So if you're developing a model and you're developing a data set, you can hold yourself to a very different standard than an open data set necessarily. Equity. This was something that I just felt, if it's not built into the systems, we already know that racism and sexism are massive issues in these data sets. We know that these are issues in the outputs that are coming out. I will tell you, every single picture that I created, if I did not specify something, every person that it drew was white. Every single one. Every time I said, draw me a picture of a doctor, a parent, and a child in a clinic. First of all, it did not know what a clinic looked like. It was very weird. Also, The doctor was always an old white man with a white beard. The parent was always a mom. And the kid, well, the kid was just it was sometimes they were a boy, sometimes they looked like a girl. It just depended. But if I didn't tell it to do something different, it just kept making images that looked kind of like that. So just keeping in mind that equity is something that we have to build into the systems. And we already know, for example, if you think about the paucity of data that we have on things like menopause, why would we study women? What a concept. You know, if you think about the kind of data that we have on why is it that we don't know, why is it that we have so much information on men's heart attacks, but not so much on women's heart attacks? Well, it's because we didn't study an entire population. Why is it that we have, you know, we still have things built into our medical records that imply that somehow Black people's kidneys are totally different from white people's kidneys? We even know that it's ridiculous, and yet it's still built into many of our systems. And so when you take a system that's already biased and you dump it into a large model, it's just going to amplify those inequities. It's not going to fix them for you. And this is, again, to that point of moral outsourcing. We have to build equity into these systems. We have to think really strategically about how is it that we are collecting and including data to ensure that it actually serves the population that we treat, as opposed to just the population that we included. We need to indicate the source of demographic data. Is this data self-reported? Is this something that was pulled? You know, I don't really want systems to be taught to guess what ethnicity somebody is. I don't think that, I think it's more useful for us to either use self-reporting or decide that that information is not relevant. So we need to figure out what information is relevant and how are we going to include or exclude it based on the kinds of outputs that we're trying to generate. When we think about disability and then we think about pediatrics, especially developmental pediatrics, how is it that we're including disability-related information to ensure that we're able to provide the best quality of care to the variety of patients that we see on a regular basis? Protection of data and privacy is a huge issue. And this is something where, again, when we think about the variety of data sets that we're dealing with, again, there's open data sets where there's not as much that we can do about that. When we think about generating our own data sets, how are we making sure that those are private? How are we making sure that those have integrity? How are we ensuring that data that needs to be removed can be removed? And if we think about the information on child sexual abuse material, once it's in the training system, once it's been used to train an algorithm, it's very, very difficult to pull that information out. So being really clear with people who are participating, what kind of confidentiality, privacy, and data protection can you reasonably expect? And if people expect something that is beyond something that someone is capable of providing, being open, honest, clear, and transparent about that so that someone can make an informed decision to say, I don't think my data should be included in this. Technological considerations. So we thought about transparency of techniques, training, and testing methodologies. So how is it that we can ensure that the algorithms are tailored to the needs of the population you're actually trying to study? How can we make sure that these are actually beneficial to a pediatric population so that it's really clear in for example, a study protocol, what your intention is and how you can test that outcome? How can we make sure that we're monitoring and documenting adverse events? What does an adverse event mean in the context of a particular system? How can we articulate that the AI or ML is trained to recognize for example, developmental heterogeneity? How can we specify how that information is trained based on age data? And so really defining those inputs and outputs in a way that is clear. Once the system is of course learning, again, we say, oh, it's this black box, we don't know what's happening. But the more granular that we can be in terms of the kinds of data that's included and how that data is labeled and when will that data expire, when will that come out, then we at least know what we put into it. If we don't even know exactly what we put into a system, and then we go, well, I don't know, the algorithm made a decision. These are not people. They are not, we don't need to anthropomorphize these systems. These are systems that are being trained. And so when we think about implications, we can think about, how is it that we can inform future studies to purposefully include pediatric data, obviously in a way that meets these ethical needs? How can we use this for QI? So we're actually looking at, existing, emerging, and future data sets to say, how is age-related data being utilized? How can we embed this in existing and future data sets or guidelines for industry standards? How can we really use ethical principles and, again, operationalize them into the building of these systems so that we're not looking back and going, gosh, we let that system do something really bad? And how can we assess these outputs specifically for age-related algorithmic bias? I was really thrilled. I didn't think anybody was reading our paper, but somebody at the World Health Organization read our paper, and I'm really thrilled it was included in guidance for large language models. We got a lot of pushback from this paper because when we were trying to publish it, they were like, well, but it's just some stuff that some of you came up with, and you haven't used this in a large group. And that's true. And our argument was, listen, these are foundational ethical principles that we can use now. And if we wait until we finish doing our e-Delphi, which is one of our next steps, there's going to be hundreds of more algorithms that haven't thought about any of these issues. So we felt it was really critically important that we got this conversation going in a more public forum, because we just weren't hearing anybody talking about the impact that this would have on kids. I want to bring up, there's something really interesting when I was tinkering with my slides, and I was doing some extra internet searches, being like, hey, like what's come out in the last couple of weeks that I wouldn't want to miss when I was talking to all of you. And so unlearning algorithms, this is something that just came out recently. There's a white paper, it's not a white paper, pardon me. There's a paper from this group, the Weapons of Mass Destruction's Proxy. And this group is fascinating because what they've done is they've actually come up with, they're like, hey, there's a bunch of dangerous data that is out there in some of these data sets. What can we do about the data that's already out there, and data that will then be put into some of these systems in the future that we don't really want out there? Things on like bioterrorism, things like the child sexual abuse material that we talked about earlier. Things that we don't want people necessarily knowing about, like making bombs. Like, you don't necessarily want to make things that much easier to do some really dangerous things. And so they really talked about how could they operationalize unlearning. So how could they take certain types of data, be able to recognize harmful data, and actually be able to teach an algorithm to remove that information, to unlearn that data over time, rather than to continue to amplify it just because it was there. I think this is a really interesting way to utilize this. So they actually came up with, it's a 4,157 multiple choice questions surrounding hazardous knowledge in biosecurity, cybersecurity, and chemical security. And so it's really interesting. Again, I'll have a link to this as well in the resources. So if it's something that you're interested in, I think it's super interesting. Let me say the word interesting 5 more times. Challenges and limitations. Like I said, this is something where a handful of us got together and started thinking, how could we take well-known ethical principles that we knew should be applied in general to pediatric research, and how could we think about those in the context of AI and ML? We're in the process of really trying to move this towards our next step, which is actually building our e-Delphi team. We've been collecting people over the last couple of months, telling them about the project, building out our team. It's really important to us that we have a really fabulous expert panel that includes lots of people who are going to have expertise. And importantly, we're including people who are actually teenagers, young people, parents, community members, because if we're not able to include those folks, the people who are most impacted, then what are we doing? What's the point? Because we've had so much interest from industry, we're figuring out who we want to partner with in industry who can help us understand, there's technical aspects of this I just don't know anything about. That is not my jam. If you want to have a philosophical conversation about like right and wrong and all of that, I'm game. But I need to learn a lot more about what kind of information do people who are programmers, who are end users, actually need to know? What are the kinds of questions and the kinds of ways of thinking that can really benefit the kind of work that they want to do? Because again, I don't think that any programmer who goes out who's trying to develop and train these models is like, I want to be evil. I want to promote evil. No, I think that most people want to do a good job. And so we need to make it so that it's easy to understand what that means. And that's part of where a lot of regulation fails. It's part of where a lot of guidelines fail, is they can say, these are these important ethical principles you should follow. Figure it out. And that's not particularly helpful for folks who really are deep in the code, who are deep in doing the really, computer science focused aspect of these things. How can we partner with those groups in order to help them do their best work in ways that benefit our patients rather than harm our patients? It would not be a talk with me if you didn't get a book review, because I love books, I love reading. So I love to give book recommendations. I asked AI to make me a cozy looking library space where there were books everywhere. This looks incredibly dangerous. Please do not actually do this for any actual space. It looks like things could topple at any time. Also, I don't know where those lights are plugged into. So I highly recommend Joy Buolamwini's Unmasking AI. Joy, when she was an undergraduate student, was doing a bunch of work, was trying to have some early AI software recognize her face, but because she is a dark-skinned Black woman, it could not recognize her. It was as though she did not exist. And then this was an issue that kind of continued to come back as she went into her graduate studies, and she's done some really phenomenal work, both in art as well as in science, talking about why it is this is important and how is it that we can actually train systems, again, to not just create pictures of a bunch of white people, and to not only recognize certain faces over other faces. And so really fascinating work, highly recommend it. More Than a Glitch, Confronting Race, Gender, and Ability Bias in Tech. This certainly gets to many of the issues that are related to AI. I think it's also a very accessible book. And then The Ethical Algorithm. This one's a little bit more technical. It's actually written from folks who are on the technical side, but if you really want to understand more deeply, how is it that you program ethical behavior? How do you program your values into these algorithms? I think this is a really great introduction to that concept. I'm learning a lot from it. I really appreciate all of your time. If you scan this code, or if you put in this little bit.ly thing, it'll take you to a Notion page. It has clickable links to everything that I talked about. So if there's any of those concepts that you want to learn more about, I highly recommend it. I know some of the issues that we talked about today are pretty tough, but I think as pediatric providers, it's really important that we're honest and open about the issues that are facing our patients, even when those things are hard. So I appreciate those of you who felt comfortable staying. And if that's something that you want to learn more about, I'd be happy to talk with you more about it. And those 2 reports that I mentioned, I think were really helpful for me to more deeply understand not only the problem, but what are some possible ways to actually build out of that. So thank you.
Questions in the room while I check what we have online?
Thank you so much for the talk. Do you know of any kind of government regulation body that's utilizing that WDMP type of unlearning algorithm? Yeah.
So that paper came out like a couple days ago.
Oh.
So I don't think we're there yet.
Cool.
This is like, the whole move fast and break things. Like, we need to move fast and fix things. And so I don't think that they've had enough time to incorporate that, but I'm really hoping they will, because it's fascinating. And that paper is super interesting for folks who are interested.
I guess just a quick follow-up question on that. I know earlier you said a lot of programmers aren't there to promote evil. But my question is, to apply these ethical principles, has your team talked about different ways to, I guess, almost convince people that it is worth it? Just because I know that we're going off the assumption that hopefully people aren't doing that.
Yeah.
But I don't.
Yeah, I think it's a great question. And this data, for example, that came out of the Stanford Internet Observatory, I don't think that the folks who created the Lion 5B whatever data set were like, let's make sure there's terrible images on the internet. It's really embarrassing for a company to have, horrible information come out about their data sets. And so from my perspective, being able to help folks understand there are business implications to these decisions. I think as healthcare providers, especially people who have funneled ourselves into taking care of children, A lot of times that's not necessarily the way that we think about things. I think a lot of times we are more thinking about things from a safety perspective. But I think it's important when we're talking to folks who have different outcome measures that they're thinking about, be like, listen, from a risk mitigation standpoint, nobody wants their company to be in a position where it turns out that you're the baddie. Like, that's bad for business. You want good PR. You want people to be satisfied with the outcomes from the algorithms that you're developing. You want people to find that your data sets are just impeccable. Like, people are going to be motivated by things like that when you think about how is there going to be a potential business outcome from this that's relevant. Also, I think it's really important for businesses to recognize that children who are in a healthy environment, we want them to grow up to be adults. We live in a capitalist society, and if you want your future customers to trust the tech that you're developing, I mean, if you think about, I mean, Facebook was brand new when I was in college, brand new. And you think about the ways that that has massively changed the way that we think about technology, the way that we think about, I mean, the whole concept of social media was totally new at the time. And the kids who are implicated right now, kids that are my kids' age, who are learning about AI, who are learning how to kind of play with this technology. If you do a search, and I did many searches for pediatric AI, almost everything that comes up in an initial Google search, at least in the algorithm, how I have trained it, is it's almost all like education stuff for kids, like teach your kids how to use AI. So there's a huge market right now for utilizing AI for kids. And so I think there are immense business implications, and those are the things that are most likely to catch the attention. All of the big tech groups have had to testify in front of Congress recently about child sexual abuse material because it's such a massive problem, and that's even without the AI component. Simply just the free economy of ideas is not all good.
Thank you.
Yeah.
All right, we do have a question online about Gemini AI. And I know that's sort of like breaking news every day about Gemini AI. This particular question from one of our adolescent medicine faculty is they heard it was taken down briefly because it was too woke.
Yeah, and you know, we're going to see lots and lots of these things. All science is political, okay? I mean, that is the reality. We all want to say, like, the data is pure. Well, one, I've told you it's not. But also, there are political forces that are going to be interpreting and assessing what it is that each of these data sets mean. There's going to be pressure to pull these things down. If anybody saw some of the images that came out of Gemini AI, it's really interesting. They were trying to train the algorithm to be less sexist, less racist, all of those things. And so it made some really funny things like the Pope as a woman, which, you know, maybe that's something you're interested in, but there are some jobs that currently are not available to women. And so it's really interesting to see how the pushback from these images. Yeah, and I'm not sure if the microphone was on. I'm going to kind of repeat the question if that's okay. So the question was, what do we do if we're approached by folks who are researchers who want to do research on data that's from your clinical environment? So for example, on feeding habits of children, and how is it that you might assess those over time? Did I get that right? Great. One, I think we need to develop those guidelines. We don't have them. I have not found guidelines that are like, I want a checklist. I want you to be able to say, wow, interesting question. Can I do this? And we need to operationalize it so that it's easy. We cannot expect every single clinician to suddenly become like a total expert in like AI decision-making and like, do I do it or don't I do it? Obviously, I would, as with most major decisions, I think it's always helpful to have an advisory team of people who know more than you do to help you think about whether that makes sense or not, to really try to understand what are their goals, how are they going to protect the data. I mean, I think Accept AI is a step in the right direction. How is it that the data is going to be utilized? What kind of information are you keeping track of? What's the privacy and security concerns for our families? How do we ensure that this information is not utilized for something negative? What are we going to do with this information? So I think this is a starting point. I think we're very early in this process. It's a great question.
Great. Okay, so we have two questions, and one is a perfect segue into something I wanted to say on closing. So Sunny Anand said, we had published an article in JAMA Pediatrics about missing race ethnicity data in most of the healthcare databases, both proprietary and public. How will this large body of missing data affect the diagnosis, prognosis, and resource allocation in healthcare?
Absolutely, and it's such a fantastic question. And this is like what I was saying earlier, if you don't have access to information, actually labeling it that you did not have access to that information is something that can be incredibly powerful, so that at least I shouldn't assume that all of that's the same. There was a study, I didn't have a chance to include it in here, but it was a study that, for example, systematically deprioritized Black people because they didn't have access to the same amount of services. And so the algorithm thought, oh, they didn't need as many services, they were healthier. And so it actually made it so that it was gonna worsen and amplify that problem that was already part of an underlying systems level issue. So that's a great question.
All right, so one of our clinical informatics fellows asked me to say more about the RFA. So I'm the director of the Maternal and Child Health Research Institute. I think what MCHRI does incredibly well is tap into the brilliant talent across the entire university, not just within the maternal and child health investigators. So I've had conversation with deans of multiple schools about how and all of the institutes across this campus about how do we work together to advance maternal and child health. So this is very much a work in progress. We haven't figured out yet what the structure is going to be. We're really going to want to talk with Alyssa and some of the AI experts on this campus about how do we really write this RFA to sharpen the focus on the issues that were raised here. That said, MCHRI has lots of funding mechanisms. So for instance, the TIP grants require by design that you have a co-investigator in another school on campus. So people who are excited about moving into this work, think about a grant that you could write with someone in the School of Education or someone in the School of Engineering or in psychology or anywhere across this entire campus tackling some of these issues. Those are $200,000 grants. So a lot more to come about the RFA, but we're really determined to lead in this space because of where we are positioned on this campus. And I'm just so grateful to Alyssa and Natalie Pagler and others who have really elevated this. At our annual meeting in the fall, we are going to have a symposium that incorporates some of this, but just stay tuned for more to come on the RFA. This is becoming a big priority for us. So with that, I want to thank Alyssa and for everybody for joining us.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.